So in terms of the background for the phase 3 CANDOR study, I think the clinical context is important. Of the 6 options we have in this setting, 4 contain lenalidomide as part of the triplet regimen. And the clinical practice currently, many patients receive lenalidomide as part of maintenance treatment. So they're either len exposed or relapsing or getting refractory to len and then progressing. So options for those patients tend to be a little bit more limited than patients who are len naive or len sensitive. So with that context in mind, I think the CANDOR trial is important. It compares carfilzomib, dexamethasone, and daratumumab to carfilzomib dexamethasone in 1 to 3 prior lines of treatment patients. So the study design was a 2-to-1 randomization schema. For every 1 patient receiving carfilzomib dexamethasone, 2 patients were randomized to receive the combination of daratumumab with carfilzomib dexamethasone. There were a total of 466 patients that were randomized to the study. The key features were 1 to 3 prior lines of treatment, patients with prior bortezomib or len exposure or even len refractory status were allowed to come on study. And patients who had received prior carfilzomib or daratumumab were also allowed to come on study as long as patients had not received those drugs in the past 6 months and had at least a partial response to those treatments. Treatment was continued until relapse, progression, or intolerance. The primary endpoint for the study was progression-free survival. And important other secondary endpoints were overall survival, overall response rate, MRD negative CR rates at 12 months, safety profile, so treatment emergent adverse events and such. So after a median follow-up of 17 months, the primary endpoint for the study was met. The KD arm had a median PFS of 15.8 months, and the median PFS on the DARA KD arm was not met with a standard hazard ratio of 0.63. The overall response rate were higher at 84% versus 73%. The MRD negative CR rates at 12 months was 12.5% versus 1.3%. All of these things were in favor of the 3-drug combination. At the median follow-up of 17 months, there were no differences between the median overall survival. Safety profile-wise, the grade 3 or higher adverse events were higher in the 3-drug combination. And most of those events, most of the difference came from the incidence of infections. So higher incidence of infections were observed in the DARA KD arm. And we've seen this signal with other carfilzomib and daratumumab based regimens. So this is a known AE to us. But what was interesting is that the DARA KD arm had a lower incidence of grade 3 or higher cardiac failure rates, which was a little surprising because this is a little bit of a concern with carfilzomib based regimens. So seeing those rates, lower rates was interesting. Even though there were no differences in the median overall survival at the 17-month time point, there were 5 treatment emergent fatal AEs on the KD DARA arm, whereas on the KD arm there were 0. And of those 5 events, 4 appear to be infection related, with sepsis, septic shock, as well as pneumonia. So bearing in mind that all the pre-specified subgroups also had the benefit, including the len-exposed and len-refractory patients, I think these results are important based on efficacy as well as the safety profile taken together. This is a good 3-drug IMiD-free regimen that would be a good option for len-exposed or len-refractory patients.